I was really quite moved by that nice little talk from Carol. I thought it was a tremendous inspiration, I suspect, to most of the audience, and it's great to hear this bringing together of tissue viability, the plan to bring it together with more in team working than has been possible in the past, and also the opportunities for academic development. Really, really good. So, if I move myself on, I'm supposed to be talking about diabetic foot ulcers, giving an overview, I think, but it's more like an underview in such a downtrodden bit of medicine. There are an awful lot of different sorts of ulcers, as you know full well. There are, say, standard neuropathic ulcers, and there are others which are perhaps the result of pressure, inappropriate pressure in some peripheral arterial disease, and then secondary infection, or you can get osteomyelitis affecting a toe, or you can get nasty little ulcers which go on and on and on for ages and ages, and they hurt a lot, unlike most of the others. Or you can get things that are just stuck and don't seem to be moving anywhere. And this is a broad spectrum of it, and it's one of the illustrations of how unscientific medicine has been in addressing this major problem, in the sense that we just call them all diabetic foot ulcers, which doesn't really start to explore the problems of, I'm going on fast. Must not be forceful in my advanced slide thing. It doesn't really give us a sort of, even if we don't use the right term, we don't use specific terms, then it doesn't really help us in terms of thinking specifically about how to assess and how to treat specific issues. But my title was Challenges of Managing Diabetic Foot Ulcers, Epidemiology, Offloading, Recognizing Infections, etc. Well, I always do what I'm told, so that is my title. I'm going to use this one because it might work better. There you go. So epidemiology, I'll start off with, since that's what I've been told to do. Here's some epidemiology. You can write it down very quickly if you like. Otherwise, I can happily make the slides available to anybody who wants them. But basically, the lifetime risk of anybody with diabetes getting a foot ulcer is something like 1 in 7. Prevalence at any one time in people with diabetes is something like 1 in 40. Median time to healing of any ulcer is 3 months. Only 2/3 ever get better without any surgery. A lot result in amputation. Actually, the incidence of amputation in the UK is lower, we think, because the data are pretty scant, than anywhere else in the world. About half that in the USA. Nevertheless, in the UK, 17% of people who present with an ulcer will be dead within 12 months. The 5-year survival of someone presenting with an ulcer is the same as carcinoma of the colon, at 50% of 5 years, about 4 times worse than carcinoma of the breast. And the problem, as far as it's possible to tell, because it is not possible to count all the dressings costs, and particularly in the community, because they tend to come under much more lumped budgets, but as far as it's possible to account, and it is an underestimate, it is 8.6% of the total NHS expenditure. So, stop it. It's always nice to press a button and things respond with enthusiasm, but not when you're giving a talk. So I suppose let's talk about epidemiology, offloading, infection, etc. Well, moving on swiftly to offloading, the non-removable fiberglass casting, of which there is more later on in today's program, at least aspects of it, is the treatment of choice for the management of the acute Charcot foot, which isn't the primary interest of tissue viability nurses, although, of course, they are often complicated by ulceration. And yet, we know from a big web-based survey that we did on Charcot that only 40% actually get provided with the treatment that they need, which is unremovable offloading fiberglass casting. And that relates to inability of people to work with the skill, people managing Charcot in this case, to work with the people who've got the skills for providing casting, unless casting is provided, they learn to do it themselves, but then that must obviously be secure, underpinned by quality standards of some form or another. So inability to work with the people, and sometimes in this sort of increasingly compartmentalized NHS we have, whereby people say, well, who's going to pay for it? Or as a hospital near where I do, where there's just an expert centre looking after Charcot patients, and they can only get for the provision of offloading if they refer to the OTs who know nothing about diabetic foot disease. And it's this sort of silly anomaly which we've really got to try and eliminate. But non-removable fiberglass casting is also the management of choice for plantar neuropathic ulcers, such as the one illustrated. And we still have the same problem. If you haven't got it in 40% of cases, people got Charcot, then certainly the same applies in people who've got neuropathic ulcers, and yet these are easily and rapidly healed if you achieve proper offloading. So we need to work much more effectively in collaborative multidisciplinary teams. Recognizing infection, the diagnosis of infection really just hastily, so I'm doing what I'm told. I've done epidemiology, I've done offloading, and now doing infection, and then I'm going to talk, after I've done that, I'm going to talk about what I want to talk about. I'm going to follow Carol's lead, saying I'm in charge because I got the microphone. And so recognizing infection, there's one message you've really got to get across, and it's said over and over again, that the diagnosis of infection is clinical. You've got to diagnose whether or not someone's got infection by the fact that it's red, it's swollen, it's smelly, or there's increased or changing discharge, and sometimes if change in sensation in the wound, even in someone with peripheral neuropathy who doesn't normally feel pain. And those are the ways that you diagnose infection. It's the only way to diagnose infection, and you cannot diagnose it. Stop it. You cannot diagnose it with a swab. It is me, I know. Nobody else will have any problem with it all day. A swab may give you a sort of idea of the bacteria which are present on the surface of a wound, but it won't tell you whether the wound is infected or not. Microbiologists, when they get a wound swab from a nurse or a doctor or a podiatrist or whatever, saying query infected, they just throw up their hands in horror. The samples which reach the microbiology lab are treated superficially. If they couldn't be bothered analyzing, if you get a lot of Staph aureus, they'll say Staph aureus. They've got 2 or 3 organisms, they'll say mixed colonizing bacteria, because they know that this is not the role of a swab. You do not use a swab to diagnose infection. You diagnose infection clinically, and then you try and work out what bacteria might be present so you can select what antibiotics you want to use. I love you, I love you. So that was my title. What about the other things? Causes of diabetic foot ulcers. If you ask someone what's the cause of a diabetic foot ulcer, well, it breaks down into what makes someone likely to get a foot ulcer, what actually causes the break in the skin, and what stops it getting better, which we can call with those long words. But there are lots of factors which variously contribute to them, bless you. Sarcopenia is a lovely word, which we never use. Sarkos, Greek tissue, penia, Greek thin. People who get foot ulcers are more likely to have thin tissues, thin skin, which is more like, it's a pre-ulcerative skin, if you like. So sarcopenia, I think, is a word that we ought to have more in our minds. Peripheral arterial disease obviously contributes to it, but then also increased pressures on particular places, either from mobilization, from congestive cardiac failure or stroke, or else deformity, can also predispose a particular area of skin to break down. But in the most cases, it's actually an accident. Someone goes over your foot with a trolley in a supermarket or something like that, or you tread on something and you don't realize it, all those things which are actually start a break in the skin at the foot of someone with diabetes. But then once it's started, what stops it getting better? Well, sarcopenia again. You've got lousy skin. It isn't ready. It's not geared up for fixing itself if something's broken it. Continuing trauma, if you've got deformity, so you're taking extra wear and tear on a particular part of your foot, or you're wearing particular shoes because you think they look smart, and indeed they do, and I can understand that's a major problem, then you will not wear shoes which someone's told you to wear because you want to wear the shoes that you want to wear, that's human nature. So continuing trauma for one reason or another. Infection stops things getting better. It actually makes things worse. But infection, remember, is not a cause of the foot ulcer. It's actually a complication. Peripheral arterial disease, of course, and professional performance, which I call the way we work, which I will come back to briefly. Thank you. Oh, God. Oh. And then the last thing is the biology of the chronic wound. And one of the great problems is because we don't know, because the level of our science is actually pretty thin, we keep on reaching out for something which might be explaining why we're not doing very well, and we don't do very well. And actually, we should be looking at ourselves more. But this reaching out for looking for an external explanation makes us very susceptible to people trying to convince us about, well, it's one of those wounds, it's undoubtedly got this or that, and therefore and that might be added, well, you need to use this product or that product. It makes us susceptible to looking for a magic solution to something that we really don't understand. Now, there is certainly a biology of chronic wound, but our insight into what is critical in the biology of a chronic wound is pretty minimal. Not only that, but it changes from time to time. These wounds go on for months. And there might be one factor that's missing today, but it won't be missing in a week's time. And so these are very, very complicated issues. All right, don't. Bless you. Current guidance. Then, of course, there are guidance. I'll show you the one from Diabetes UK, which is the Putting Feet First document, which came about 2 or 3 years ago, because this emphasizes the need for, us all to work. We're in this complex issues of what we're trying to do. We're looking at trying to prevent foot disease, we're trying to treat it when it occurs, and when it has been healed, we're trying to prevent recurrence new ulceration, which is 40% at 1 year, and also early mortality, as I was explaining about the high mortality that you get with, bless you, the high 5-year mortality that you get. But this is not just something that involves the person who's running a specialist service. It goes right from the earlier stage, especially when trying to identify the people at risk. And then you've obviously got a care pathway which crosses from people with lesser knowledge of diabetic foot disease right through to the people who get the referrals later on. And there is evidence that the faster someone with a new foot ulcer is referred to an expert center, then the better the outcome in terms of eventual healing and in time to healing. In that pathway, I showed the Diabetes UK one. NICE has guidance. The original one was originally a Royal College of General Practitioners document about type 2 diabetes. That came out as an early NICE thing in 2004, but that's just about type 2 diabetes, and it's out of hospitals. It's just about prevention, effectively. Then there was an inpatient one which came out about 3 years ago, and they're now working on another one which is bringing it all together, which is what Diabetes UK did 2 or 3 years ago. And I think it's that triggered NICE to actually come up with guidance for an integrated pathway, which is what we're eagerly waiting for. But if someone has an ulcer, then there are treatments that you might want to adopt. Treatment of infection. Infection is just a complication of ulcers. It's not necessarily something which doesn't cause it, but nevertheless, when someone first appears, it's the first thing you do, partly because it's making the thing worse, and partly because it's very relatively easy to treat. Then you've got to consider revascularization. Has the person got peripheral arterial disease we need something doing about? And a word of warning here, don't put too much faith in the ABPI. It's a toy, I know it's a toy, and I know that in the ADA, the American Diabetes Association, all practitioners are required or encouraged or certainly paid to do an ABPI on everybody with diabetes once a year. It is quite a good test of peripheral arterial disease. If your ABPI is low, then you will have decreased arterial perfusion. The great problem with ABPI is that you cannot assess it when it's normal, because someone might still have arteriosclerosis. You will get a normal ABPI, but it doesn't mean that they haven't got peripheral arterial disease. And the majority of people with diabetic foot ulcers do have arteriosclerosis, and you cannot compress the arteries with a sphygmomanometer cuff. So a low ABPI indicates low arterial pressure, yes, certainly, but a normal one doesn't exclude it. Offloading, we've already talked about. And then wound debridement, cleansing and dressing, which is the key part of the maintenance of chronic ulcers, as you know full well. And the only thing I'd just say here, and I'm not going to enter it, is the choice of dressings. it should be evidence-based, and I think with this increasing scientific underpinning of your profession, I think it is going to be an increasingly important part of your assessment of the treatments which are available. But in the absence of evidence-based for wound dressing products, whether they're dressings or whether they're applications or other advanced wound therapies, we should be leaning over backwards to examine the evidence. And in the absence of strong evidence, we should to adopt the acronym, American acronym of KISS, keep it simple, stupid. In other words, keep your approaches to management simple. Don't necessarily go for the latest, most glossy, and most expensive thing that's been you've been introduced to. And then frequent review is obviously a key part of management. Outcomes. Amputation is the thing that we count the most, but it's not the most important. These are data from which we published 10 years or so ago. I guess they're a bit out of date. A large number of consecutive referrals to a specialist centre. And you look at ulcer outcomes, 2/3 heal, a number don't. 8% result in some form of amputation to get rid of it. 8% of the people who got an ulcer die. But what we're really doing is talking about people, not about ulcers. And there is a great danger that we become ulcer-focused. Not least in misunderstanding the person's psychological burden. It is very easy when managing wounds, especially in a clinic where there's lots of people around, everybody's jolly, rather than a one-to-one basis. And there's a sort of almost an artificial jollity. You say, ooh, that looks good. Oh, yeah, great. Well, we'll just do this and see you again in a fortnight, and jolly dee. That's because your eyes are focused on the foot and not on the person's face. And you need to always bear in mind the suffering that the person is not admitting to, partly because they don't like to admit to it, and partly because they want to get out of the place as quickly as they possibly can. But if you do consider patient focus, you'll see that, okay, 2/3 of ulcers might heal within 12 months, but at 12 months, only 50% of people are ulcer-free. 8% of ulcers might get resolved by amputation, but 10% of people have had an amputation. So amputation is a measure, and it is used repeatedly of the effectiveness of outcome, but it's not a very good one because we should be thinking about the person. But because it is used repeatedly, that's what I'm going to talk about now. This was a paper looking at ulcers and their variation in papers published in the 1990s. This is minor and major amputations combined, all the papers published in the 1990s, and showing a 200-fold variation in incidence of ulcers. The lowest in Madrid, I don't actually believe the data. Oh, God, no, better delete that from the video. It's amazingly good. Even though the European Wound Management Association conference is in Madrid this year, maybe that's why it's in Madrid this year. But there's a 200-fold variation from the lowest to the highest between different centres that there are. And if you look at England, these are data which were widely published when they came out a couple of years ago, indeed hitting even BBC News, showing 10-fold variation in the incidence of major amputation between different PCTs. And these are PCTs defined by the person's residence, not by the hospital where they were treated. And there are surprising black spots, here dark red, in the southwest and the northeast, and a surprising pale spots up the A5 corridor, which you wouldn't normally expect it to be. And there are a number of reasons why that might be, and I'll come on to those in a second. But this just shows you the major amputation by PCT, the same data, if you like, from the lowest to the highest. And you can see that if you talk about postcode lottery, if you present with a foot ulcer in this particular PCT, you're that much likely to, in terms of rate per people 1,000 with diabetes, to have an amputation. And this is major, losing your leg. Whereas if you're in this PCT, you're that much likely. And that's a bit worrying, really. So these data are amazingly important, despite the weakness of using amputation as a measure of outcome of foot disease. So why might there be variation between PCTs? Well, race is important. It's important the way that you wouldn't think it's important, in that Caucasians do badly. And that Asians, the incidence of amputation in Asians is about 25% of people who are Caucasian. And in blacks, it's about half, 0.6% of people who are Caucasian. And these data contrast completely with America, whereby blacks have double the incidence of amputation in America than whites do, and that is because of access to primary care. And that's why our government is actually trying to adopt the American healthcare system. You better delete that from the video as well. So race undoubtedly plays a part, but in the way that you wouldn't think, and perhaps this Caucasian dominance might explain the red spots in the southwest and the northeast. It's difficult to know, but it certainly accounts for the very low incidence in London boroughs, where you've got a much younger population, much more mixed race, etc. But there are other factors which contribute. There was a study published in 2000, looking at incidence of amputation around the world. These are major and minor amputations together, and there were 4 UK centres. And you can see that amongst these 4 UK centres, that the incidence of amputation as defined in this particular study varied 4-fold. They're all sort of northeasty sort of places, although Leicestershire is actually the county of Leicestershire, so it's both urban and rural, and the others were towns. But there was 4-fold variation in the incidence of amputation between these 4 centres. And it comes back again to other factors. Now, race might contribute to the low incidence of Leicestershire, except that, because they're a very high population of people who are Asian. But it's still variation which is worrying. And people in Leeds, I think it was, who then decided to look at the data from the 4 English centres, and they presented sample cases to the surgeons working in the 4 centres. Only 3 of the 4 centres actually agreed to take part, but the vascular surgeons from the other 3 centres did, and the conclusion of this particular paper was that the attitude of the vascular surgeon was a factor which contributed to whether or not that particular problem would have been treated surgically. So there's again a clue. But you mustn't think that if there's variation, it's all the fault of the experts in the hospital. Because it's this pathway that we've got. If someone comes late from wherever they've been managed before, often the horse has bolted. There's very little a vascular surgeon can do. And this is why this whole principle about rapid referral is so important. And so it's in pinpointing the fact that attitudes might vary. It's not just the attitudes of the people who are in specialist centres. And then, so moving on quickly to the impact of multidisciplinary team working, as a result of this work that was done looking at these centres, the people in Middlesbrough, where you have a single hospital covering a circumscribed part of the community, said, look, this is terrible, what are we going to do about it? And they set up a team, a multidisciplinary team, and this was looking at major amputations only. This was their incidence, 3 per 1,000 people with diabetes lost a leg each year. Within 4 years, they had reduced it to 0.76. And the same was shown in exactly the same year in Ipswich, which was running at 4 per 1,000 per year. And they set up a multidisciplinary team. They reached out to people in the community saying, please, not bring out your dead, but please give us your ulcers as quickly as you can, because the sooner we can assess them, decide how we can best, with you, manage them, the better the outcome is likely to be. And within the same 4 years, Ipswich showed a reduction, which was, the other one being 4-fold, this is 5-fold, from 4 per 1,000 down to 0.67, and it's 2005, because it was maintained. They showed it was maintained for the succeeding 5 years. So it wasn't just they were holding them back because they were doing an initiative to reduce amputation, but it's actually been maintained over 10 years. So this is just a very illustrative example that it's not reaching out for something off the shelf which is very expensive and which is new, but it's actually changing the way that we work, the way we work along the whole foot care pathway. And the last slide, which just skipped over, does nothing but introduce this, which is something which is the latest news, really. Because there is guidance available, and yet we still have massive variation in outcome, using amputation as an outcome measure despite its limitations, people need to know, each of us needs to know how good we are. So we work in isolation, even isolation and multidisciplinary team. We think we're good, but we don't know we are good because we never actually count how well we do by looking at sample populations with other centers around the country. The National Diabetes Audit already exists, and it's got an inpatient audit, which you've probably heard of. It's got a pregnancy audit, which started last year, and the latest one, which is starting this year, is the foot care audit. And you will see it has now been funded and adopted by some pretty heavy bodies, and it will be starting this summer in England and in Wales. And the principle is that every newly occurring ulcer will be documented, and its outcome will be documented. And there will then be an attempt to link that with ulcer type and with outcomes to try and see how it links in with variation in the structure specialist services. And one particular example of an illustration which might be used is the one here of a funnel plot. And basically, if you're in the middle of the funnel, then your center, if it was that one, is doing quite well. So the people who manage this number of ulcers, or when the data are corrected for depth, severity, if you like, then you would expect the number to be healed to be there. You're doing pretty well if you're in amongst that bunch. If you're down here, however, you're a bit borderline, whether you should be expecting that number to heal or this number to heal, but you're below what other people are achieving. And if you're up here, you're doing rather better than what other people are achieving for that particular corrected population. So these are the sort of data which can be generated, and I think the new audit is going to be a fantastic breakthrough, enabling people to change. And so to finish with my last slide, which went over. Thank you. I was starting to talk about epidemiology, offloading, recognizing infection, etc., which I've done, and I've talked about 7 other things. Causes, which break down into those 3 groups, current guidance, which I showed, but emphasizing this earlier referral to an expert MDT, which is not an absent body, it's a body to which all of us should be linked, working as part of the same pathway. Treatments, obviously treating antibiotics, peripheral arterial disease, and offloading, but remember KISS, and the outcomes with their limitations, and the reasons why we might have geographical variation. Race contributes, but the way we work also contributes. Thank you very much, Gina.